Hello, I'm Michael Sgro, consultant pediatrician at St. Michael's Hospital in Toronto with an interest in neonatal hyperbilirubinemia. I'm here with you today to talk about neonatal jaundice and a bilirubin for every baby. I'm going to start with a bit of background on neonatal jaundice. Neonatal jaundice is an extremely common problem seen in a vast majority of healthy newborn infants. When caring for infants, this is one of the most common medical problems a healthcare provider will deal with. Long-term complications do occur when severe hyperbilirubinemia occurs, and this can occur in otherwise healthy, well newborn infants. In addition to hyperbilirubinemia, there's been a increased awareness and reporting of severe hyperbilirubinemia and kernicterus in the last 15 years. This is particularly worrisome given that severe neonatal hyperbilirubinemia is primarily a preventable illness. There are a number of factors that have likely played into a resurgence of severe hyperbilirubinemia. The largest factor is likely a change in neonatal care in the last 20 years. The length of stay for a healthy newborn infant in hospital has significantly decreased over that time. This has caused a shift in presentation of neonatal hyperbilirubinemia from in hospital to after discharge from hospital. Estimates in recent years have shown significant increases in readmission for neonatal jaundice in healthy newborns, to a point now where this would be the leading cause of readmission for newborn infants after discharge. It would not be a concern if this readmission was occurring and jaundice was being managed, but there also has been an increase in the reports of severe hyperbilirubinemia. These reports have been from many jurisdictions, including in Canada. Canadian data collected by our group in the last several years have shown that severe hyperbilirubinemia continues to occur in Canada. The majority of these infants were readmitted from home, ABO incompatibility, followed by G6PD deficiency, were the most common etiologies, and many of these infants were incompletely investigated at the time of presentation. Severe neonatal hyperbilirubinemia does have its consequences. This consequence is bilirubin encephalopathy. Bilirubin encephalopathy occurs in two basic formats. There is acute bilirubin encephalopathy. This is a clinical syndrome that is present in the newborn when they present with their severe hyperbilirubinemia. They can present with lethargy, hypotonia, and poor feeding. This can progress to hypertonia, a high-pitched cry, fever, seizures, and subsequently coma. In the long term, these infants that develop severe hyperbilirubinemia and acute bilirubin encephalopathy can develop a clinical sequelae called chronic bilirubin encephalopathy, or also referred to as kernicterus. This is a severe developmental disorder with chorioathetotic cerebral palsy, seizures, developmental delay, hearing deficits, oculomotor disturbances, mental deficiency, and dental dysplasia. Can this bilirubin encephalopathy be prevented? The answer is yes, but the answer is yes, it is a preventable disease if the hyperbilirubinemia is treated in a timely manner. Delayed intervention leading to severe hyperbilirubinemia can lead to the long-term damage, which is not treatable. Kernicterus, or bilirubin encephalopathy, has been estimated to be quite rare. The incidence is not known, but estimated to be about 1 in 100,000. We do know in Canada that bilirubin encephalopathy does occur. Estimates are not clear in Canada. In addition to the clinical syndrome, chronic bilirubin encephalopathy has MRI findings that are characteristic, and this is staining of the basal ganglia bilaterally and the subthalamic nuclei. Studies suggest that MRI findings are very consistent and specific to severe hyperbilirubinemia and bilirubin encephalopathy. but sensitivity and specificity of MRI findings is not well documented. Most MRI case series on newborns are a small number of cases in infants and children already diagnosed with kernicterus. This next slide shows you 3 rows of images. These are MRI findings in an infant with kernicterus or chronic bilirubin encephalopathy. And if you look at the top 2 rows, you will see staining of the basal ganglia bilaterally. For comparison, the 3rd row is a normal infant without dark staining of the midline or basal ganglia structures. I mentioned a few slides ago that we know chronic bilirubin encephalopathy is occurring. We have estimates from centers outside Canada. Between 2007 and 2008, our group looked across Canada to see, was this happening in Canada? We had a total of 20 cases reported and confirmed to us during this time period. These cases came from across the country. This number is quite rare, but shows that bilirubin encephalopathy is occurring in Canada. Our data suggests that the rate may be higher than previous reports. Other literature had suggested between 1 in 100 and 1 in 90,000, but our 2-year study suggested that this number was closer to 1 in 40,000. With the acknowledgement that severe neonatal hyperbilirubinemia is occurring and infants, albeit small numbers, are having both short-term and long-term complications with bilirubin encephalopathy, what are the next steps? Well, the Canadian Pediatric Society has recently put out new guidelines. They were put out during the time we were collecting data on bilirubin encephalopathy. Do these guidelines work? This is a 2-part question. Are they effective? And is there implementation of the guidelines? First, a historic perspective on management guidelines in neonatal hyperbilirubinemia. For most of the last 20 years, the management has been based on a combination of risk factors and clinical assessment. We look at newborn infants, see if they have risk factors. With accumulation of risk factors and clinical judgment, a decision will be made to measure a bilirubin level in this infant. The most common risk factors are near-term infants, infants that become jaundice early, infants with ABO incompatibility or other hemolytic disease, including G6PD, infants who have previous siblings that have required treatment for hyperbilirubinemia, Asian population, cephalhematomas, and if infants had been screened and been in high-risk zone. When the new Canadian Pediatric Society recommendations came out, they elected to move toward universal screening and recommending that all newborn infants in their first 72 hours of life receive either a serum bilirubin measurement or a transcutaneous bilirubin measurement. The feeling in the guidelines were that a transcutaneous bilirubin measurement is an acceptable method for routine screening. There are other guidelines though, both in other jurisdictions and other bodies. Some guidelines recommend routine measurement of bilirubin levels in all babies. Other groups continue to recommend a targeted approach in that you would look at risk factors and clinical assessment when deciding to measure a bilirubin level. Once a bilirubin level has been measured in an infant, whether by blood work or by a transcutaneous bilirubin meter, decisions regarding this infant's management will then be based on the clinical scenario, the gestational age of the infant, and plotting the bilirubin levels on 2 charts. One is a risk nomogram. This chart estimates the likelihood that this infant will end up in a range where they need treatment for their hyperbilirubinemia and helps guide follow-up. The second chart is a treatment curve. And this, along with gestational age and risk factors, guides clinicians in the decision to initiate treatment for the hyperbilirubinemia, primarily phototherapy. Once a decision is made in an infant with hyperbilirubinemia to treat, the first line of treatment is phototherapy. When treating neonates with hyperbilirubinemia with phototherapy, there are a number of issues that need to be considered. First is the dose or the intensity of the phototherapy lights. The second is the distance the phototherapy units are from the infant. And the last is the surface area of skin that the infant is exposing to light. When looking at phototherapy intensity, intensive phototherapy, whenever possible, should be used. It is the most effective means of treating neonatal hyperbilirubinemia, and it has been well shown in multiple studies to end up with the most rapid and effective reduction in bilirubin levels. Intensive phototherapy may be applied by overhead units or by fiber optic blankets. The units need to have their output measured as per guidelines, as over time there may be degradation in the photo output of the unit. If an infant has severe hyperbilirubinemia presentation or is not responding to initial phototherapy treatment, a number of considerations need to be taken into account. One is to increase the surface area exposure to light. Phototherapy should go to being an overhead unit along with a fiber optic blanket below the infant. This will allow exposure of the infant's skin to phototherapy on both sides of their body. Phototherapy should not be ordered as double or triple phototherapy. Additionally, consideration can be given to moving overhead lights closer to the infant. This would increase the intensity of the phototherapy. Whenever this has been done, you need to be cautious that an infant is kept thermoregulated and not losing extra fluids, as when a light is moved closer to the infant, there may be more heat produced. All infants under phototherapy should have their temperatures monitored. Infants under phototherapy will have increased fluid losses, and it is important to monitor fluid status, and fluid status should be managed based on the infant's fluid status, their weight, and monitored appropriately. If we have effective treatment and we have a means of measuring bilirubin levels in infants, what are the barriers to appropriately managing newborns? As mentioned earlier, early discharge from hospital has transferred the location in which the infants become jaundice, and this is a barrier. There are educational gaps in healthcare providers, physicians, in their management of jaundice. Since early discharge, there's often inappropriate follow-up in that there are gaps in time when the infants are not seen for a number of days. The test is invasive, and some people have reluctance for invasive testing. And there are parental and healthcare misconceptions, including that jaundice is because of breastfeeding and that sunlight is a solution for neonatal jaundice. There are non-invasive serum bilirubin machines that allow us to avoid some of these barriers. The older devices used to measure bilirubin levels transcutaneously were not effective. Newer devices now use multiple wavelengths of light and analyze these multiple wavelengths to determine, through algorithms, the bilirubin level, accounting for hemoglobin and skin color. These newer non-invasive bilirubin devices have a number of pros. They're not painful, they're quick, they're rapid, they're portable, and you reduce the risk of infection as you're not doing blood work. There have been a number of studies to show that transcutaneous bilirubin meters are now an effective way of estimating bilirubin levels with some limitations. But many of these studies were done in a very controlled environment with either a research nurse or research coordinator assessing each infant. What about real life? What about multiple users? What about multiple skin pigmentations? can we rely on a transcutaneous bilirubin meter as a form of screening and managing infants with jaundice? Our group set out with an objective to determine the usefulness of a non-invasive bilirubin meter in predicting serum bilirubin levels and affecting management in term and near-term infants in an inner-city hospital at the time of discharge. The study was approved by the hospital's Research Ethics Board. We included term and near-term infants who were visibly jaundiced at the time of discharge from the postpartum floor. We excluded infants who had received or were receiving phototherapy, and we obtained informed consent from all parents. This was a prospective cohort of jaundiced babies on our postpartum floor. They were healthy newborns. The current standard of care when this study was done was prior to the new Canadian Pediatric Society guidelines, and only infants that were visibly jaundiced were included. Our sample included a wide variety of ethnic groups reflecting various skin tones. And you can see that there was a relatively small number of Caucasians in our population. We had a wide range of bilirubin levels and had a number of infants in phototherapy range, 20%, and had infants in high and intermediate risk groups. Study found that there was a very good correlation between transcutaneous bilirubin levels and serum bilirubin levels. The correlation dropped slightly as bilirubin levels rose, and the bilirubin meter tended to overestimate bilirubins as the bilirubin level was higher, but there was a wide spread. In conclusion, our study showed that a non-invasive bilirubin tool is an effective means of estimating bilirubin levels in a multi-ethnic population with multiple users. The precision of the device is limited in that it cannot replace serum bilirubin measurements, but is helpful in clinical decision making. Serum bilirubin continues to be the gold standard, but a transcutaneous bilirubin measurement can be useful as an assessment tool in newborn infants. Can screening all newborns for hyperbilirubinemia make a difference? We've now said that there's been some changes in guidelines. There are new ways of measuring bilirubins in newborn infants, and there have been some studies to try and assess whether routinely checking bilirubin levels at the time of discharge or in the first days of life does make a difference. One study presented here is a large cohort of newborns when they looked at two time periods. One, before they were routinely measuring bilirubin levels in all infants, and then done again after they started measuring bilirubin levels in all infants. And they found the frequency of severe neonatal hyperbilirubinemia was reduced, and the hospital readmission rate was reduced. There was a second large study, again, looking at screening by looking at two different time periods. One, before they were routinely measuring bilirubins in all infants, and then done again after they started measuring bilirubin levels in all infants. And again, they found that there was a reduced incidence of severe neonatal hyperbilirubinemia in the group that was being assessed bilirubin levels routinely. In conclusion, all infants need to be assessed for neonatal hyperbilirubinemia in the first days of life. There have traditionally been more than one means of doing this. One has been routine screening of all newborns measuring bilirubin levels. The other has been a risk-based approach. There is increasing evidence that routine measurement of bilirubin levels is a cost-effective way of gathering information and is more informative than solely a risk-based or clinical assessment approach alone. I'd like to thank you for taking time to listen to this talk today regarding neonatal jaundice. If there are further questions or inquiries, the Canadian Pediatric Society website and the American Academy of Pediatrics website provide links with guidelines and information on neonatal jaundice. Thank you.